Good. Good evening, and I hope that that is coming up. What I'm actually going to talk about, not just about squint surgery, I'm going to talk about the management of squint because it doesn't always just involve surgery. And I think it would be important to go through that. I think it's worth saying at the outset that Moorfields is a slightly unusual hospital. It's a standalone eye hospital. So we see our patients after the adnexal team have started the journey with either immunosuppression or with orbital surgery. We have a link orthoptic team who spend time with the adnexal team, so they know the patients very often well before they come up to the strabismus service. So what I want to do is just start with some background, and I think you'll all know that thyroid eye disease is also called Graves' ophthalmopathy, and the literature can get quite confusing. I'm going to talk about what we see in our clinics, the problems that we find our patients have, and how we deal with them. You know it's an autoimmune disorder. You know that you get inflammation of your lids, the fat in your orbits, the skin of your eye, the conjunctiva. The bit that particularly interests us as strabismus surgeons is the eye muscles. It affects far more women than men, hyperthyroidism, but it's worth just being aware that when men get thyroid eye disease, they tend to get it very badly indeed. So most of our patients have gone through having had hyperthyroidism. You're very unlikely to get significant problems if you're euthyroid or hypothyroid. You may get some double, but you're not likely to have a major issue. And so most of our patients will develop their eye signs at about the time that they become hyperthyroid. The vast majority of people don't get major disease, I'm pleased to say. It's about 1 in 5. And there's about 5% that get serious disease. And the serious disease in particular is thyroid optic neuropathy, which requires decompression. And decompression is important to us because many of our patients have been through decompression. The vast majority of our patients have symmetrical disease. It's very unusual to only have it in one eye, but you may have it much worse in one eye than the other, which explains why we have to do often asymmetric intervention. So what actually happens? Well, you know that you get swelling of the orbital fat and the muscles, but those muscles become edematous and they don't become stronger, they become weaker, they become soggy. So that means that they don't move normally, so they become heavy and tired, rather like if you have swollen legs, you don't feel like moving them very fast or very far. And it's the same with your eye muscles. When they're thick and waterlogged, they don't move normally, they don't move as fast, and they often don't move at the same time. So things feel out of sync, and you often feel that the images are separating, even if you don't have frank double vision. You'll feel that they're just not holding together or coordinating. The eye movements are slower. So the whole thing feels very sluggish. And when it gets significant and the eye movements become very incongruous, you will get double vision and see two images, and those can be side by side, above each other, or even tilted. So the double vision may not just be looking straight ahead. It can sometimes it's only in one position, such as looking up or looking down or to the side. And it can be very variable, particularly depending on how waterlogged your muscles are. Now, this little comment here about IR, MR is inferior rectus, medial rectus, superior rectus, lateral rectus, and superior oblique, because the muscles that are affected, the most commonly affected one is the lower bottom muscle, the inferior rectus, which gives you vertical double vision. And it means that your eye can't look up. So this gentleman is looking up and this eye is not moving. So if you're looking downward, it'll often be fine, but as you look upward, it starts to become more and more difficult. But it tends to involve multiple muscles and not just one, but it can start with one and move on to the other, which is why you feel your double vision can be changing. So what does it do? Well, some of you will know that this is Marty Feldman, who had thyroid eye disease, and he was offered surgery, but decided that his trademark unusual eyes were something that were worth keeping. Apart from Marty Feldman, there are very few people who feel that having thyroid eye disease is beneficial. They feel disfigured by it. Double vision stops you driving. Now, not everybody wants to drive, but for many people, it's a mark of independence. You can't get to the shops, you can't go and see your friends. And if you live outside of regular bus routes, you are very, very dependent then on either your friends, your family, or taxis. So for many people, not being able to drive is a major, major loss of independence. They even lose their jobs. So it damages your quality of life, how you feel about yourself. You may lose your job if you have to drive. So it's a very miserable thing to have. I just need to remind you that legally you can't drive if you've got uncontrolled double vision. You can drive with DVLA's permission if you have a prism or a patch and you've adjusted to that double vision, but it is something that is notifiable and you have to stop driving until you have permission to drive. So what do we do in the orthoptic? When you come and see us, the first person you'll meet is one of our team who's an orthoptist, and they will measure your vision. They'll measure your squint using these prism bars, which have plastic with jumps in them to allow us to try and assess, measure, and see if we can fix your double vision. First of all, we've got to look and see if you hold your head in a funny way to try and control your double vision. Many people find if they put their chin up or chin down, it can either help or make it worse. We check your vision to make sure that it's not been affected by the thyroid. And we look at your eye movements and whether you've got double or not in different positions, because one of the cardinal things about thyroid is that your double vision can get worse in different positions. So we've got to assess that by getting you to look in different positions and look up and down. And a lot of people say that that's very tiring and it's very unpleasant, but it is necessary so that we can plan what is best for you. We look at how you hold your eyes together, and that's called your fusion range, and that's important. We'll find that many patients with thyroid have got an amazing ability to hold their eyes together, even though their eyes aren't quite in the right position. And that's an important factor. You may find yourself put on a chart and holding a stick, trying to plot it onto the graph paper, and that's called a Hess chart. And we'll examine your 3D vision because that's what will be affected if you're starting to get double vision. And then we'll do the standard eye checks that you're probably all used to, sitting on a slit lamp, having your eyes checked, having the back of your eyes looked at to make sure your optic nerve is healthy. So you're going to do this time and time again throughout every talk about thyroid. Stop smoking. Because it's very important. But we find that a lot of our patients are smokers, and it's something which seems to be very bad for eye muscles. Medical treatment's important, although in our hospital we don't manage the medical side. That's often
so that's what I'm saying, but the point is
it's managed by
when they say we're on it together, they're on it together. So
sorry, can I just ask everybody to please mute if they're not the speaker? We can hear somebody's in the background.
Well,
so, as Rebecca said, we do it in a strict order, and the reason that we do it in a strict order is you'll find out later. If we do it in the wrong order, you're not going to get things in the right place at the right time. So we've got to get the orbital decompression done first by the orbital team, then the strabismus team take over and fix the double vision as best we can, and then the lid surgeons take over and put the final finishing touches. And the reason for that is that some of the squint surgery that we do can alter your lid position. So if I have your lids fixed and then I do some squint surgery, your lid position is not going to be optimal. So I know it's boring, but it's an essential part of trying to get it into the best place possible. So what I'm going to say is based on what we see at Moorfields. Now, I think it's fair to say that in 2020, we didn't do much thyroid surgery at all. We did do some, and I think again, we're finding that many hospitals like ours are not allowed to do any, even patients with double vision, we can only do urgent surgery at the moment. So this is a snap backwards to look at what we expect to get back to. So as I said, it's far more women than men have thyroid disease, but when it comes to thyroid eye disease, then getting bad enough to get into a strabismus clinic, it's 2/3 women to 1/3 men. So men get it, when they get it badly. 50% of our patients in clinic are smokers compared to 19% in the whole of the UK. So smoking is really something that's bad for your eye muscles. A large chunk of our patients, about 1/4 of them, have been through the adnexal service and have had serious enough disease to require orbital decompression. Most of our patients have had steroids, radiotherapy, decompression. They've had a lot of treatment by the time they get to us. Now, one important point, and I think this explains why we try and do it in the order that we do, the vast majority of patients who've had orbital decompression will go on to have squint surgery. So orbital decompression is often the start of having double vision and needing intervention. So there's no point having any squint surgery and then having a decompression. Now, a large number of our patients, when they have surgery, will have what's called an adjustable technique, which means that you're partially awake for it. And I'll talk about that a bit later. So very few patients get into our strabismus clinics without having had a decompression or significant and heavy medical treatment. So people have been on quite a journey before they get to us. So as I say, about 50% of our patients are smokers compared to less than 20% in the community. So what do we do after we've assessed your squint, worked out what it's got? So to get rid of your double vision, the quickest and, I suspect, ugliest way is to use a patch. It works, it gets rid of your double vision, but you lose your field. So if you shut one eye, you can't see a bicyclist on the inside or something coming on the outside. So it'll be much more difficult to navigate and you'll have to be careful not to bump into things. We can put a foil, and you can see here, this is called a Bangerta foil. We can also use Blenderm tape just to cover up one spectacle lens. Now, what this shows you is that you will get light through it, so you'll be aware of people on one side, and many people prefer that to a patch. We can put prisms on. This is Hillary Clinton when she required prisms, when she had double vision. And you can see that you get lines on a sheet of plastic that we put onto your glasses. Now, it goes under a water seal, rather like old-fashioned car discs, so it doesn't cause any damage whatsoever to a spectacle lens and can be taken off and changed very easily. It needs a little bit of care. We advise washing them with baby shampoo, with a baby toothbrush, just to get any dirt out of the ridges. And they can go yellow if you smoke. And if they're very old, they tend to peel off at the corners, so they need replacing. One of the problems with prisms is that they work in the direction of the prism, but if you look up and down, they don't work as well. So if you look to the side, you see through the edge of the prism, which isn't helpful. So if you've got a squint, as I said, that we measure is different in different positions, the prism is often not helpful. And if you've got a very big squint, a prism isn't perfect. We use a lot of botulinum toxin. People have heard about this to treat their wrinkles. It was originally put onto the market to treat squint, and we use a lot of it at Moorfields. We haven't found it very helpful for most of our thyroid patients because it produces a change, and thyroid is already a dynamic condition. So it's change onto change. Sometimes for our chronic patients who've got a small deviation after surgery, it can be helpful, but it's not our go-to treatment for someone arriving in our clinic. So it's temporary, it wears off, it needs repeating. And so it's not ideal for most people with thyroid. Now, this is a slide from my colleague, Professor Rose, to give you an idea of why decompression can create a problem. The commonest decompression in the past has been to take out the medial wall and the floor. And this is the bony side wall here, and these are the thickened muscles. So if you take out some of the bony wall, you can see that the muscles fall inward. So when they fall inward, they pull your eyes inward. So you can see here, this eye, the white bit is the lens in the eye, so it's pointing in that direction. And you can see that the eye has turned inward with the in-pulling of that thickened muscle. Now, there are, and Rebecca can talk about this, there are different ways of decompressing. You can take out just the floor, just the medial wall. And our surgeons have moved to, if they can, just taking out the outside wall, because that produces less displacement of muscles. It doesn't produce such a big decompression. So if you've got sight-threatening optic nerve, being pushed and, those swollen muscles damaging it, the treatment almost certainly has to be to take out the inside wall and the floor of the orbit. And that will give you double vision in a vast majority of cases. If we can get your surgery before that happens and take out the outside wall, you're probably not likely to have much double vision at all. So your orbital surgeon will choose what operation is best for you depending on your condition. So you'll read in the paper, lots of published papers about how much double vision you get, but as I say, if you're able to have it done with the temporal side, you're going to have somewhere between 0 and 9%, about less than 10%. Whereas if you have other decompressions, you at least 1 in 2, and as I said, of our patients who come in with strabismus, the vast majority have had to have medial wall and orbital floor surgery. Now, what we've noticed in the last few years, and I think this is a huge credit to Ugogo, there seems to be less severe thyroid eye disease. People are managing thyroid right at the beginning better, and that good management is likely to lead to less patients getting optic neuropathy and the need for a decompression. So the vast number of, more than 3/4 of our decompressions now are what we call aesthetic. In other words, they're not for sight threatening. They're because people's eyes are bulging, they don't look good, but they're not at risk of going blind. So, as I say, if you've had to have a decompression, you're almost certainly going to have squint surgery. So the first thing we need is that things are stable and settled. So if you've had a decompression, we usually say that that's about 3 months after the decompression procedure. If you haven't had to have a decompression, say you've had to have steroids or radiotherapy, then we often will wait 6 months because there can be changes, and it's the old tailor's thing of measure twice and cut once. So what we're aiming for, we're aiming to get you as good as we can. And the most important position is what we call primary, which is looking straight ahead, and looking down, which is where you'll go downstairs, where you'll eat, where you'll look at your iPad. Most people, but it does depend on your occupation, aren't as troubled by double vision in up gaze as they are in down gaze. So we're aiming to get your head straight and give you the biggest area of single vision that we possibly can. But because those muscles don't move normally, we can't shrink them down. It's going to almost certainly have some double vision in some positions of gaze. We're just trying to give you the best and most helpful positions that we can. Success will depend on, depending on who you read. Some people say they've got an almost 100% success. I don't think anybody at Moorfields would suggest that they had. We find that quite regularly our patients require more than one operation. In fact, the vast majority do. And we, as I say, we use adjustable stitches to try and optimize the outcome. And all of our patients have been better. I'm not saying they're perfect, but most people have been glad that they have had their surgery. So it's a worthwhile intervention. But it's not, there are risks with every operation that you have. You'll have scars on the surface of the eye. If your eyes are dry and irritable anyway, that can make that worse. They'll be red for at least 10 weeks. You can get an infection. The needles that we need to use during the operation can pass through the eyes and put infection inside the eyes. You can get inflammation on the surface of the eyes. Thyroid muscles are bulkier, heavier, and they tend to slip. Your lid can get pulled down, which is why we do your lid surgery after we do any strabismus surgery. So there's quite a need for second stage, but in a very few number of patients, we'll need to do a third operation. So squint surgery prior to the pandemic was one of the commonest, it was a very common operation. There's about 10,000 cases a year done on the NHS, obviously not all for thyroid. And the vast majority of those operations are going to be done under a general anaesthetic. So you have to be fit for general anaesthesia. Now, the oldest patient we've operated on at Moorfields is 95, and you can have surgery from the age of 6 months. Now, thyroid is obviously an adult problem. So it's not your age which defines your surgery, it's the fact that you're fit for a general anaesthetic. So the muscles that we normally operate on are the lower muscle, the inferior rectus, sometimes the superior, the medial, which is the inside one, which pulls your eyes inward, and the outside one, which pulls your muscles out. Now, one of our problems is that the muscles supply the blood to your eye. So if we operate on too many muscles, we will damage the blood supply. So in the main, we can only operate on 2 of these rectus muscles. We can't operate on 4 of them. So that often limits the amount of surgery and the type of surgery that we can do because we can't damage your blood supply. So what we do when you're asleep, we open up the skin of the eye, the little white, and we use scissors to do that. And we then hook up these muscles and then we move them. And usually we weaken these thickened edematous muscles, or sometimes scarred muscles. But we very rarely, but we can tighten them, but we tend not to tighten them as a primary procedure. So usually we will do a vertical muscle, and usually that's the bottom muscle because the likely thing is that you can't look up. So it's the tight inferior rectus that's giving the problem. So we loosen that. If you've got horizontal double vision, it's usually in the distance. So we'll operate on the inside muscles, usually on both eyes. And sometimes we do both together. So this is a lady who's had to have her, you can see that her lower or her left eye is pulled down because she can't look up. And she's had some corrective surgery to get her straight. But what I would like you to notice is that the lower lid is sagging a bit because the lower muscle's been moved. And that's going to need corrective surgery by the lid team. And that can't, that's why you don't want to do your lids before you've had your squint done. So if you've got a vertical squint, we usually loosen, it's often that we need to loosen both muscles, right and left. But if it's really only one, we'll only do the one eye. We don't like using the adjustable technique on the lower muscles because there's about a 1 in 3 chance that with the help of gravity, that those muscles will move later. So we don't want to risk that. So that's why your surgeon will often say, we're going to do that operation all with you asleep. Now, the horizontal squint, the vast majority of these problems are interned squints, usually because you've had decompression and the orbital walls have allowed the medial rectus to fall inwards. And so what we do is loosen the inside muscles to allow those eyes to straighten up, but still you may have some problems on the extreme side gaze. So the adjustable technique that your surgeon may well talk to you about allows us, like sort of adjusting shoelaces, to do the operation, to put the muscles where we think we've calculated based on measurements is the right place to put it, but we obviously need to fine tune that. So we put the skin of the eye pulled back, and this is the stitches that you will see, and they've been put into a part of the eyeball, and this is the stitch here. So what you do is you tie it into what you think is the best position, and then afterwards, when you've woken up from general anesthetic, we'll ask you to look in various positions. We'll have your eye position measured. We'll see whether you've got double vision or not. And when we will move those stitches to get them into the best possible position. Now, it sounds a bit creepy, but you can do this from somebody of about 15, 16 onwards. And it does allow us to optimize where the eye position is to give you the best result. So double vision is very disabling. You can often lose your independence. It can stop you driving. That may have huge impacts on your employment. I don't believe anyone can tell you we can make you normal again, back to where you were, but we can try and give it the best that we can to give you single vision, looking straight ahead and looking down, and as wide a field as we possibly can. It's likely to need more than one operation because you may well have horizontal as well as vertical problems. And we can use medical treatment, prisms, or a patch in the interim whilst it all stabilizes. But you're very likely to have some double vision on the edges and the extremes of gaze. Now, the aim is to get you back to the equivalent of driving because that's got a legal requirement of field and of vision. And I think you're going to hear this in loads and loads of talks. If you can avoid smoking, because smoking seems to be one of the things which predisposes to severe thyroid disease and certainly to severe squint. So, but there's no, by the time you come to my clinic, having had your decompression with double vision for a year, stopping smoking is almost too late. It's always a good thing for your general health, but it's not likely to solve your squint problem. So that's got to be done right at the beginning of a diagnosis of thyrotoxicosis to prevent your running into trouble. Because the aim is to put strabismus surgeons, decompression surgeons, and lid surgeons out of business and looking at something else to deal with, so that we don't have to deal with thyroid problems if we can get them aborted right at the beginning by good medical and prompt medical management. That's where we would like to be. Thank you.